Hello and welcome to GP Notebook TV. My name is Anish Kotecha and I'm a GP in South Wales. Today I want to discuss with you the second part in our two-part series on the management and the assessment of CKD. This is looking at the NICE guidance, the NG203, that does talk to us about the assessment and management of chronic kidney disease in adults. If you remember, in the first part of this series, I talked you through the types of people that we should be investigating and the investigations of note. In this video, I want to touch upon risk assessment. I want to touch upon the referral criteria as well as pharmacotherapy. So let's make a start. When we're looking at risk assessing adults with CKD, we should be using the 4-variable kidney failure risk equation to assess their 5-year risk of needing renal replacement therapy. And we should be referring adults for specialist assessment if this risk is over 5%, if the ACR is 70 milligrams per millimole or more, unless they're known to have diabetes and already been treated, if there's a sustained decrease in the eGFR of 25% or more within the past 12 months, or if hypertension remains poorly controlled despite 4 or more antihypertensive medications, and lastly, if there's a known or suspected genetic cause of renal artery stenosis. Now, let's talk importantly about pharmacotherapy. Initially, I'd like to make the point that it's really important to educate our patients and give them the information they need to make good lifestyle modifications. We should be talking to our patients and their families about this. It's of course an area we do really well, and I think we should continue to do that because our patients are really grateful. Within this, we should be discussing disease progression, treatment options, self-management and lifestyle modifications. And don't forget to provide dietary advice on potassium, phosphate, calorie and salt intake as appropriate. But do remember that low protein diet should not be offered to adults with CKD. Now, when we're thinking about blood pressure control, we should be aiming for a clinic blood pressure of below 140/90 for adults with CKD and an ACR of less than 70 milligrams per millimole. Now, of course, if the ACR is above 70, then we need a tighter blood pressure control, and that should be below 130/80. We should be offering an ACE inhibitor, as we know, or an ARB, to adults with CKD who have diabetes and an ACR of 3 milligrams per millimole or more, hypertension and an ACR of over 30, or an ACR of greater than 70 or more. That's irrespective of hypertension or cardiovascular disease. This should be titrated to the highest tolerated dose, and do remember to monitor renal function 1 to 2 weeks after initiating these medications, or indeed with dose escalation. We should not be offering renin-angiotensin system antagonist medications if the pre-treatment potassium is more than 5, and we should be stopping them if the potassium increases to 6. Now, we should be offering antiplatelet medications for the secondary prevention of cardiovascular disease and following the NICE recommendations for the use of statins in adults with CKD. Now, I hope you found this summary of the guideline valuable as a reminder about managing CKD in primary care. As a recap, we've gone through who we should be testing, what investigations we should be using, how to risk assess people, and how to treat with medication, and the referral criteria for secondary care. Thank you very much for watching this GP Notebook TV update, and I hope you found it helpful. Please stay tuned for more videos on the latest developments in primary care. Thank you.